Hello, my name is Nyan. I'm one of the diabetes endocrine registrar from Lister Hospital.
And I'm Kavita Narula, one of the diabetes and endocrinology registrar as well.
Welcome to Lister webinar. This is episode 11, Management of Diabetes in COVID-19. Diabetes is one of the leading causes of morbidity and mortality throughout the world. It is associated with several macrovascular and microvascular complications that can impact the overall patient survival. Studies have shown that COVID-19 is associated with hyperglycemia, particularly in elderly patients with type 2 diabetes. Hyperglycemia and DKA are contributing to morbidity and mortality in COVID-19, even among patients without previous diabetes diagnosis. So it is quite difficult to manage extreme glucose dysregulation in patients hospitalized with COVID-19. COVID-19 precipitates atypical presentation of diabetes emergency, such as mixed DKA, euglycemic DKA, and hyperosmolar. Persistent hyperglycemia more than 10 millimole per liter can be associated with 4 times greater risk for mortality in patients with COVID-19, which can even increase to 7 times among those without previous diabetes diagnosis. Although optimizing glycemic control is important, but we need to review few diabetes medications during COVID period. For example, like metformin, which can cause lactic acidosis if patients are dehydrated. So patients should stop taking metformin and follow the 6-day rules when they begin enroll. Another important medication is SGLT2 inhibitor, such as canagliflozin, dapagliflozin, and epagliflozin. There is a risk of dehydration and euglycemic DKA during illness. Again, they should stop taking SGLT2 inhibitor and follow the 6-day rules. Metformin and SGLT2 inhibitor should be discontinued for patients with severe symptoms of COVID-19 due to the risk of acute metabolic decompensation. However, discontinuing these drugs is not recommended prophylactically for outpatients without any symptoms of infections. GLP-1 agonist, DPP-4 inhibitor, sulfonylureas, they are safe, they can continue. Few medications need to be reviewed in case of AKI. 6-day rules, which is very important, especially for type 1. Blood glucose level can be high during illness, even if the patient is not eating. So we advise to increase blood glucose monitoring. Few diabetes medications such as sulfonylurea, insulin, may need to be increased temporarily during illness. Insulin, we never stop insulin. Insulin dose may need to be increased during illness, especially if ketones are present. Carbohydrate, ensure patient maintain hydration and enough carbohydrate intake. If the patient is not eating or drinking or patient vomit, we suggest to replace meal with sugary fluid if possible. If blood glucose levels are high, maintain fluid intake with sugar-free fluid. If sugar levels are low, encourage regular intake of sugar fluid. Ketone. In type 1 diabetes, we advise to check ketone for every 2 to 4 hours. Give extra rapid acting insulin dose in addition to the regular doses based on total daily insulin requirement if ketones are present. We advise to drink plenty of water again to maintain hydration and to flush through ketones. So Kavita will talk about UK guidance for COVID-19 and diabetes.
So since the COVID-19 has happened, a lot of people has come together to provide a front door guidance for patients with hypoglycemia or diabetic, as this can cause increased risk of mortality and morbidity in these patients. So COVID-19 infection in people with or without previously recognized diabetes increase the risk of emergency stage states of hyperglycemia with ketones such as DKA or HHS, and we will require to adjust standard approaches to diabetes management in these patients. We'll go through the guidance right now. So early on in admission, people with COVID-19 infection seems to have greater risk of hyperglycemia, especially with ketones. These patients include patients who are already on SGLT2 inhibitors or patient newly diagnosed with diabetes. They're at higher risk of having DKA. And they can have either just a general DKA, or it can have a mixed DKA or with HHS or just HHS alone. It's also important to remember that SGLT2 inhibitors, which we will go into later, can precipitate euglycemic ketoacidosis. In these patients, it's suggested that anyone who comes through the hospital with possible COVID-19 should have their blood glucose checked. And if they are diabetic, they should have their ketones checked as well. If they are not diabetic and their blood glucose on admission is more than 12, then their ketones should be checked as well. And as Nayan has mentioned before, all SGLT2 inhibitors should be stopped with anyone who is unwell with infection as per a sick day rule. It is important to know that COVID-19 can cause ARDS, or called lung leak. So these patients, if they're not diabetic and they were not to have hyperglycemia, I know that a lot of people will approach with a cautious fluid approach, but please remember that in DKA and HHS, they are severely dehydrated, hence fluid requirements in the initial phase is important. Fluid resuscitation is quite important. If there are any inquiries regarding the fluid use or the insulin use, it is important to contact the diabetes specialist team early on. We've also seen that patients who are diabetic that are admitted in ICU have significant insulin resistance, specifically the type 2 diabetic patients, and their IV insulin may go up to 20 units per hour, and they're often NASH prone, so feeding may be accidentally interrupted, so they may have paradoxical risk of hypoglycemia as well. So it's very important to monitor their blood glucose closely. So like we mentioned, and like with all other patients, we approach everyone with ABCDE approach. Remember that they can be breathless from metabolic acidosis or from COVID-19 or a mixture of both. Ensure that all the patients who are admitted have their blood sugar tested. And as mentioned, if they are diabetic, then they should have their ketone checked. If they are non-diabetic and their blood glucose is above 12, then they should have their ketone checked. Stop the SGLT2 and metformin in all patients. The SGLT2 inhibitors are CANA, DAPA, EMPA, or ertugliflozin. If they are at risk of AKI or hypertension, then all the ACE inhibitors, ARBs, NSAIDs should be stopped as well. If the blood glucose is more than 12, rule out DKA or HHS, which we will go into later on, what the criteria are and what the treatment would be like. Also remember to consider urgent causes of hyperglycemia, such as new presentation of diabetes. It can be type 1 or type 2, depending on age, weight, family history, or it could just be sepsis related. Also, please remember to check their feet as well, because they can have other complications from diabetes, such as osteomyelitis or diabetic foot ulcers. Also check their recent HbA1c to see how well controlled their diabetes has been in the last 3 months, or if it's not done, then please send an HbA1c as well. If they've recently been started on steroids, they can present with hyperglycemia as well. So persistently high glucose level may need treatment with subcutaneous or IV insulin. And as mentioned, it's important to seek diabetes team advice early on. It's also important to know what each blood ketones level means. So blood ketones less than 0.6 is quite safe. Between 1.5 to 2.9, these patients are at an increased risk of DKA. So I encourage the patients to drink oral fluids if possible. Otherwise, IV fluids would be something that will be useful. Consider giving rapid-acting insulin, although we have to see if the blood sugar has been chronically raised. Then knowing the cause of the chronically raised blood sugar and treating that with appropriate medication and long-term insulin may be more useful. If the blood ketones are more than 3 or greater, it's important to check the pH and bicarb to make sure that they're not in DKA. For patients who come in that are on insulin, always ask them what kind of insulin they're on, and always continue the usual long-acting basal insulin. I'll explain later on in the later slides what the long-acting basal insulins are and what these insulins should never be stopped. If they're very sick and not eating, and they're especially in type 1 diabetic patients, they're at high risk of going into DKA. So starting a variable rate insulin infusion or sliding scale would be beneficial in these patients. If the patients are wearing diabetes technologies such as continuous glucose monitoring of Freestyle Libre, then patient can continue to check their blood sugar through that. If the patient is on insulin pump and no specialist advice is immediately available, start either variable rate insulin infusion or subcut basal bolus insulin regime and disconnect the insulin pump for the time being. We have 3 cases with different scenarios to be discussed today, and each will go into the management of different kinds of diabetic emergency. The first case that we'll go into is a typical case of a 19-year-old gentleman who's come in with diffuse non-specific abdominal pain with nausea, vomiting for the last 2 days, dry cough and breathlessness for the last 7 days. He lives with his family, and his sister is positive for COVID-19. He does not have any drug allergies, and he does not have any past medical history. Again, as mentioned, it is important to do primary assessment ABCDE. So the same approach is used here. So A, patient is vocalizing, airways patent, no intervention needed. B, his respiratory rate is 23 and his saturation is 94% on room air with good air entry bilaterally. So we've done a VBG and a chest x-ray at this stage. For C, cardiovascular, his heart rate is 110 and his cap refill time is 4 seconds with a blood pressure of 100 systolic. His JVP is not seen. So we got in an IV access, did some routine bloods on these patients, gave him some IV fluid resuscitation, started monitoring his urine output either through catheter, convene, or ask the patient to tell us his urine output, and ECG. D, we assessed his GCS and it's E3, V4, M5. His pupils are reactive to light equally. We did a blood glucose and a capillary ketones at this point. On assessment of E, this patient had sunken eyes with a dry mucosal membrane with generalized abdominal tenderness. There's no ulceration at the feet and the peripheral pulses were intact. We then did a urine dipstick. So this is the bedside investigation for this patient. As you can see, the patient's pH is 7.18. He's clearly acidotic. His lactate is 2.8 and PCO2 is 3.8. Likely metabolic acidosis. His glucose is 28. And so for this patient, he's got a raised anion gap metabolic acidosis with hyperglycemia. To calculate the anion gap, the formula is sodium minus chloride plus bicarb. And in this case, it is 26, which is raised. The most common cause of raised anion gap metabolic acidosis with hyperglycemia is DKA. So this patient, the current impression is that he's got possible DKA. We don't know the ketones yet. To recap, this patient is a 19-year-old man who's got abdominal pain, dry cough, breathlessness, with a raised anion gap metabolic acidosis and hyperglycemia. His glucose is 28, as you can see on the screen. His heart rate is 110, and his blood pressure is 100 systolic over 72. So investigations that are necessary for this gentleman is capillary ketones to check what the ketones are, urine dipstick as a septic screen, urine culture as well, ECG. Blood tests that we would send would be full blood count, UNEs, plasma glucose, LFTs, plus amylase, CRP plus minus cultures. And imaging that we would do is chest x-ray, and we would also get a COVID-19 swab for this gentleman. So the results for the investigation, so the capillary ketones is 4, which means that this is consistent with diabetic ketoacidosis. His urine dip showed glucose 4+, leukocytes trace, and nitrites negative. ECG showed a sinus tachycardia at rate of 100. Blood tests showed hemoglobin of 130, white cell of 11.1, and he's lymphopenic, lymph of 0.75. His creatinine is 110. His potassium is 4.6. So he may have some mild AKI, but we don't know what his baselines are. His chest x-ray showed bilateral shadowing, and it was reported as probable COVID-19. So current impression, he's got diabetic ketoacidosis, and we will go into what the criteria are in a minute. And he's got possible COVID-19, RAG red. So for diabetic ketoacidosis, the diagnostic criteria are ketonemia. We would prefer that you do the capillary ketones more than 3, glucose more than 11, and a bicarb less than 15, and or venous pH less than 7.3. So goals of management, it is quite important that these patients are, they are very dehydrated. So it's important to restore their circulatory volume, and that will be by giving IV fluids. Correction of acidosis is through insulin infusion. So give insulin. It is also important that insulin can shift potassium into the cell, and so it is important to correct any electrolyte imbalances that can happen by giving KCl in most fluids, depending on what the potassium level are. And we have to find out why this patient went into diabetic ketoacidosis. So treat the precipitating factors, and the most important is usually sepsis, infection. So address the cause and continuing care by monitoring the patient and switching them to variable rate insulin once they're out of diabetic ketoacidosis. So for rehydration, the type of fluid that you would use are 0.9% sodium chloride, and that's the standard protocol. We would give the fluids depending on what's been shown on the screen at the moment. So it's 1, 2, 2, 4, 4, 6. So first R, so normal saline 1 liter in the first R, then the second bag goes through 2 Rs, third bag 2 Rs, fourth bag 4 Rs, fifth bag 4 Rs, and sixth bag 6 Rs. KCl may be added to the bag depending on what the potassium level will be. And we would need to monitor the blood glucose and capillary ketones during the time that we're doing fluid resuscitation. We need to do VBG to monitor the potassium as well. It is important to monitor urine output, and specifically in patients with possible COVID-19, they may go into ARDS. So we need to monitor the urine output quite carefully. And especially in the young patients, they can have complication of cerebral edema. So it is important to monitor their GCS closely as well. So the rate of infusion, rate of insulin infusion that we would start at would be 0.1 unit per kg per hour. And so it's written up already in one of the section of the drug chart, but basically you need to sign the section that says 50 units actrapid made to 50 ml of normal saline. it is important that we write up some 10% dextrose 8 hourly, to be running at 8 hourly, once the blood glucose is less than 14, to avoid the patient having hypoglycemia. And as mentioned before, the fluid resuscitation is 122,446 hourly, plus minus 20 to 40 millimoles kCl. So if the potassium is between 3.5 to 5.5, we need to add 20 to 40 millimoles of kCl to the normal saline fluid. But if the potassium is less than 3.5, then these patients actually, we need to consider central line, as when we do start the insulin infusion, it is going to shift the potassium into the cell more, and they're at higher risk of hypokalemia. Note, it is quite important that these patients have their long or medium acting insulin prescribed in the start and to be given at the start of their DKA management. So it is important that we tell the nurses that these patients require hourly blood glucose, ketones, mu score, and GCS done. We will do the 2 hourly BBG to monitor their potassium. If the patient is vomiting or is obtunded, then getting an NG tube in would be something that we can consider doing. We can either ask the patient to do pass urine in the bottle to monitor their fluid balance if they are well enough, or we can insert catheter or convene. But it's quite important to do fluid balance well, especially if you're thinking that these patients may have COVID-19. These patients also need to be given antibiotics if their precipitating cause of DKA is possible sepsis. And it is important to give VTE prophylaxis, as they are much higher risk of getting DVT or PEs. And especially in patients with possible COVID-19, they are at higher risk of the VTE event anyways. Complications of DK to watch out for are hypoglycemia, hypokalemia, cerebral edema, especially in the younger population. And it is important to note that if the patient is very acidotic, it is never wise to give sodium bicarb IV, as this usually makes cerebral edema much worse. Pulmonary edema can also be one of the complications of DKA because of the amount of fluid we need to resuscitate these patients. Hence, fluid balance are important. And as mentioned, DVT and PE are quite a common complication of DKA. So severe DKA are defined as when the ketones are more than 6, bicarb less than 5, pH less than 7, potassium less than 3.5 on admission, GCS less than 12, saturation less than 92% on room air, systolic blood pressure less than 90, and heart rate less than 60 or more than 100. It will be wise that these patients are cared for in level 2 care if they have any of the presenting features. If they get better after resuscitation, then they can go to a normal ward as well. So once the DKA has resolved, it's important to switch to variable rate insulin infusion. And this variable rate insulin infusion can be stopped, and basal bolus insulin can be started once the patient starts eating and drinking. It is important to get the diabetes team to review these patients within the 24 hours period. Like I mentioned before, that long-acting insulin should never be stopped, especially in patients who go into our type 1 diabetes and go into DKA. The long-acting insulin I wanted everyone to be aware of are Lantus, Levemir, and Tresiba. Okay, so the second case Nayan will be.
Second case, this is a referral from surgery. A patient 44 years old. He was found to have a generalized weakness, lethargy, nausea, anorexia. 6 days after operation, he had a C5 and C6 esophageal decompression. He has a past medical history of type 2 diabetes, dyslipidemia. Drug history, he is taking delaglutide, 1.5 milligrams weekly, SGLT2 inhibitor, canagliflozin, 300 milligram OD, atorvastatin, 10 milligram OD. So review the patient, go through the ABCDE approach. A, airways patent. Patient was quite tachypneic, respiratory rate of 24, but oxygen saturation was 94% on room A. So we requested chest X-ray, VBG or ABG. Patient was tachycardic, heart rate of 110, blood pressure stable, JBP is normal. So got IV access, send the blood, give the IV fluid and ECG. GCO was 15. We checked the capillary blood glucose and capillary ketones because patient was taking SGLT2 inhibitors. So clinically, he was quite dehydrated with dry mucosal membrane. So send a urine dips. Investigations, got a VBG first, pH 7.1 and bicups 4.8. He was quite acidotic. And PCO2 2.0, PO2 was normal, and lactate was 0.8. Capillary blood glucose 9.4, which is normal, ketone 4.3, which is high. Other investigation are unremarkable. So our impression is euglycemic DKA, which was caused by the SGLT2 inhibitor. So our management plan as use a DKA protocol with aggressive IV fluid resuscitation, but lower insulin dose than standard as an infusion regime. We need to check hydration status, fluid balance, electrolytes, glucose, capillary ketones, venous bicarb and pH. Monitor closely like we did in DKA. But he remained acidotic even 24 hours after starting the insulin infusion. pH of 7.28, bicarb of 15.4, and blood ketone was 2.1. So he was transferred to ITU. It took about 92 hours for acidosis to resolve, but patient began well and he was discharged home well the following day on insulin glargine 6 units once a day and his routine delaglutide. So learning point from this case, SGLT2 inhibitor should have been stopped before surgery or during any medical annals. Regardless of the mechanism, treatment of euglycemic DKA require the same approach as hyperglycemic DKA, but with less insulin. We suggest to use dextrose rather than saline because these patients rarely have a high blood glucose, and this offers important therapeutic opportunity to administer the larger dose of intravenous insulin if needed in order to suppress ketosis. So we have another case. Kavita will talk about this one as well.
So the third case is an 85-year-old gentleman who's come in with a dry cough for the last 3 days with increasing confusion. He lives in a nursing home where other residents has been tested positive for COVID-19. He does not have any drug allergies. His past medical history includes Alzheimer's, dementia, hypertension, and previous CVA. His drug history, he was on Ramipril 10 milligram once a day, aspirin 75 milligram once a day, and amlodipine 10 milligram once a day. So again, we go through primary assessment, A, B, C, D, E. So for A, his airway was patent, no intervention needed. B, he was tachypneic with a saturation of 92% on room air. There was equal bilateral air entry. We did an VBG or AVG as well as a chest X-ray. C, his heart rate was 130, he was tachycardic, with a prolonged cap refill time at 5 seconds and a blood pressure of 100 systolic over 72. His JVP was not raised. We started him on IV fluid resuscitation, did some blood tests on him, got ECG done, and started fluid balance monitoring. And D, on assessment, he had GCS of E3, V3, and 5. Pupils were equally reactive to light. We did a blood glucose as well as a capillary ketones. And E, he had sunken eyes with dry mucosal membranes and bibasal crackles on chest auscultation. There were no ulceration on the feet, and the peripheral pulses were intact. We then got a urine dipstick at this point. Investigations-wise, we ended up doing an ABG on this gentleman, and his pH was 7.35, so he was not acidotic. His PO2 was 8.7, so low. His bicarb was 17. Sodium was 147, potassium 3.7. Glucose was very high, was 38. So as mentioned before, this patient is a suspected COVID-19. Anyone who's non-diabetic and blood glucose tested more than 12, we should check their ketones. His lactate was 3.2 and his chloride was 102. So we did check the ketones and it was 0.2, so it was less. His creatinine was 362, baseline of 80, so he's got AKI, at least stage 3. His urea is 32, his white cell is 10.9, and his lymph was 0.54. So at this point, the chest X-ray was done, and it showed bilateral haziness again. And again, it has been reported as probable COVID-19. So we calculated this patient's serum osmol as the blood glucose was more than 30, and the serum osmol was 364, which is more than 320. It's quite significant. To calculate serum osmol, it is important to use 2 sodium plus glucose plus urea, all in millimoles per liter. And anything above 320, it's important to think of HHS as well. So in this gentleman, he has HHS as his primary diagnosis, complicated by acute kidney injury, and he also has a probable COVID-19 red. So hyperosmolar hypoglycemic state, or HHS, the characteristic features are the patient are quite dehydrated, so they have hypovolemia, they're quite unwell with it, they've got blood sugar of more than 30 without significant hyperketonemia. So usually their ketones are less than 3, and they usually don't have any acidosis. So their pH is usually more than 7.3 and bicarb of more than 15. Their serum osmol, as mentioned, is usually more than 320 milliosmol per kg. You can have a mixed picture of HHS and DKA, so the patients may be very hyperglycemic with a serum osmol of more than 320 and also may be very ketotic. So it's important that as these patients are severely dehydrated, we do fluid resuscitation, and IV fluid with normal saline is the initial treatment. Vigorous initial fluid replacement alone will already result in a reduction in plasma glucose, and some patients will not require IV insulin infusion at all, but their glucose will drop quite a lot with just fluid resuscitation alone. You can see an initial rise in sodium, but it is not an indication to use hypotonic fluids. This is usually within the first 24 hours, and the sodium should be on a downtrending after that. Low dose of IV insulin, which is 0.05 units per kg per hour, should only be commenced once the blood glucose is no longer falling with IV fluids alone, or if the patient has significant ketonemia, which is ketones more than 1. So we are aiming to have positive balance of 3 to 6 liters by 12 hours for these patients, as they're so severely dehydrated. So it is important that there are loads of diabetic emergencies that can occur, and we've seen lots of them in COVID-19 patients. It is important to manage it well because their mortality and morbidity is much higher. If you can take anything from this presentation, then these last few slides are really important. So any patients that are suspected with COVID-19 should have their blood sugar checked. There's low threshold to suspect for DKA and HHS in these patients, or a mixed picture. If they are diabetic, make sure that they have a recent HbA1c at least within the last 3 months, or at least send one off when they come in. Check ketones if blood glucose is more than 12 in non-diabetic patients, but if they are diabetic patients, then check ketones in all of them. If blood glucose is high, but patient is not ketotic or in HHS, giving start doses of short-acting insulin is not going to help very much. Rather, it is important to know why their blood sugar is high. So it would be important to check their HbA1c and discuss with diabetes team for possible initiation of insulin or sulfonylurea, depending on how high the blood glucose was and their eGFR. Like Nayan has mentioned, metformin and SGLT2 should be stopped in patients who are coming in with COVID-19. SGLT2 inhibitors should be stopped in all patients who are unwell, actually. SGLT2 inhibitors are cana, DAPA, and empagliflozin. These are important medications. They are at high risk of euglycemic DKA, and treatment is similar to DKA treatment, but the fluid used is mostly dextrose fluid rather than normal saline. Patients coming in with COVID-19 should be assessed for AKI, and all their nephrotoxic medications should be stopped. And it is important to know that COVID-19 patients with DKA or HHS may require a very large amount of insulin due to severe insulin resistance, and they may require up to 20 units per hour of insulin infusion. And after their diabetes emergency has resolved, sometimes they can go into profound hypoglycemia because their insulin need has reduced remarkably after they're out of the infection. Fluid balance and clinical status is most important in fluid management in COVID-19 patients. Either get them catheterized or convene, or get them to pass urine in a bottle and measure their fluid output, urine output. Be mindful of ARDS, hence cautious fluid, but initially, if they are in DKA or HHS, they will require initial phase of fluid resuscitation. So don't be hesitant to give them fluid at that point. And don't forget to check the patient's feet and look for possible ulcers or any diabetic complications. It is also important to do a VTE prophylaxis in these patients as they're in such a high risk of having thrombosis. Do not stop basal insulin, especially in type 1 diabetic patients. And we've mentioned before what the basal insulin are. Be aware that DKA, HHS guideline, as well as sick day rules for diabetic patients can be found on the intranet in the Knowledge Center. Please approach diabetes outreach team with well in advance and ask for their advice. You can see the rota on the Rota Watch to see which consultant is on call, and you can contact them. Be mindful that COVID-19 is a new challenging disease, and we are all learning, hence stay up to date with the literature. These are the references used. Thank you so much.
Right.